Okay, we are 60. It's a nice number, I guess. Probably some other will join, but in the meanwhile, I can start to introduce this seminar. Actually, it's going to be the 15th seminars for the HITRIplus project. It's quite a great goal. And this one is going to be presented. We have the honor to have here Laura Vallow. She is a professor of radiation oncology and chair for the Department of Radiation Oncology at Mayo Clinic in Florida. And importantly, she serves also as the director of heavy particle therapy at Mayo Clinic in Florida. In this presentation, she's going to explore the history of the ion therapy, but let's say the most breakthrough for this presentation will surely be the focus on the challenges of bringing carbon ion therapy to the United States. As you know, United States were the first where the ion therapy originated in Lawrence Berkeley National Laboratory, but there have been no ion treatment in the US since the early 19th. So now we know that US is more than approaching actually. Laura will show us that we are very close to have a carbon ion also there, and definitely will be something that will change a lot the history of carbon ion radiotherapy. So Laura, I give you the floor, and thank you again very much for being here and for presenting this talk. Thank you. Laura, you are muted.
Can you hear me okay?
Okay, great.
Okay, so thank you, Angelica, for the introduction. I'm just really thrilled to be here. I've met several of you along our travels, but really I'm looking forward to meeting everyone in person. And I know that this group really holds a wealth of information that's going to be critical to our success in the US. So I'm going to start with just a brief introduction of Mayo Clinic, kind of what we are, who we are, talk a bit about the survey of the current landscape, some basic particle physics. I want to go over quickly how we got here, why Florida, why now, and then how are we addressing those challenges? And then kind of go through some of the logistics and basics of our project, really to share our enthusiasm for our project, but also to highlight some of the work and the collaborative work that's already begun. So Mayo Clinic is a very large hospital network. There are 3 sites. There are 3 Mayo Clinic sites. So there's a site in Rochester, Minnesota, Phoenix, Arizona, and in Jacksonville, Florida. We have over 71,000 total staff. We have 7,000 consulting staff and clinical residents with 5 schools. We see almost 1.3 million unique patients from every state and 130 countries. So we typically think of the cancer center specifically as one cancer center with 3 doors. As you're probably all aware, the sister sites moved forward with protons, Rochester in 2015 and Arizona in 2016. With really Rochester being one of the busiest proton practices in the country. So we are certainly leaning on them for their clinical expertise, and we'll be moving forward with protons in 2027 with the hope of carbon in 2028. This is a drone view of our campus. It's ever expanding. You can see over the horizon is the Atlantic Ocean. And the site over here is where our new integrated oncology building is being built. And I'll show you some more details of the facility. But this is an overview of our beautiful campus. So Mayo Clinic Florida, although we're part of the Mayo Network, we are a nationally recognized NCI Comprehensive Cancer Center. So we're independent of the other two sites in our NCI recognition. And we currently have 7,800 staff working here as of 2021. And there's a lot of growth happening with the expected growth to be over 10,000 in the next 5 years. So just as Angelica alluded to, we were very successful with heavy ion therapy early on, back in 1930 when Ernest Lawrence won the Nobel Prize in physics for building the first cyclotron. And that went on to clinical trial use at Lawrence Berkeley Labs with actually treating cancer patients in the 70s. There were clinical trials looking at helium, neon, and carbon at that time. Unfortunately, in 1976, the cancer center closed, and that was basically due to funding. And so the door closed in 1993. And fortunately, our colleagues in Europe and Asia were able to pick that up and continue the development and treatment of carbon therapy. But we're excited that there has been such growth with protons in the US and abroad, with 15 carbon centers worldwide. But bringing this back to the US it's a huge responsibility and quite an honor, and one that Mayo Clinic has certainly taken on a lot to make this happen. So as you all know, there are currently 15 treating carbon ion centers in the world. There are 3, to my knowledge, that are under construction, with ours being the 4th. So you're all aware of the huge volume of proton patients that are treated worldwide, with over 300,000 patients by the end of 2020. But if you look at the volume of carbon ion patients at 2020, it was about 50,000 patients. And so, it seems like a low volume in comparison to proton, but 50,000 patients is still quite a high number of patients. And we'll be excited if we can foster that growth into North America. So what's the big deal about heavy ion therapy? Well, there's the Bragg peak, but it's really the RBE in particular for carbon that sets it apart. And so sort of a joke, but when we talk about what's the big deal, so you see the human-sized conventional equipment that we quickly outgrew into building-size equipment with proton machines. And now we're looking at much larger equipment that's actually facility-sized equipment. So you can see that the big deal is really the big size. Part of the limitations in bringing carbon ion to the US has been the extreme cost in the facilities construction. So looking at proton versus photon entrance and exit doses, we know that protons can lower that entrance and exit dose while delivering the same dose at prescribed depth. So thinking about dose as energy. So we know that 1 gray is 1 joule per kilogram, and a cup of coffee has 100,000 joules of thermal energy. But unfortunately, we can't use that energy for cancer treatment. So it's really how the energy is transferred that is important, and that defines what the dose really means. So in terms of linear energy transfer, we know that low LET basically is not so concentrated, can give multiple single strand breaks. As you increase the LET, you can see there in the middle, you'll have double strand breaks and single strand breaks. But then when you get to a certain energy, you get overkill. And so you see you're actually absolutely destroying. So really want to focus on the medium LET range. So this was a wonderful publication from Marco Durante and colleagues that really nicely illustrates some of the potential advantages of carbon ion therapy. And here you can see this cluster destruction there from the high concentration of LET. So these are the things that we're really hoping to capitalize with carbon, and you're all, experts in this. So certainly the angiogenesis effect, the radioresistance, the hypoxia, and the effects on the immunotherapy. So thinking about RBE, we know that RBE is a range, and it can range anywhere from 1.5 to over 4. And so we're prescribing the RBE as a constant, but we know that the RBE varies based on tissue type, on patients, on tumor type. And so thinking in the future, is there a way that we can personalize and customize RBE for every individual patient? So that's some very basic oversimplified review. I wanted to move on and talk about what is happening at Mayo Clinic Florida. And so back in 2019, we announced that we would be building a proton therapy facility at Jacksonville. And that was in June of 2019. And then shortly thereafter, sort of the heavens opened, and it was decided by high-level Mayo leadership that we would also include carbon ion therapy in that proton expansion. So from June to November, our direction quickly changed. So as I'm sure you're all aware, taking on a project like this, the first thing Mayo in particular will do is divide it into 1 million work streams. So we have a lot of complicated work streams. You all know better than I how intricate this work is and how complicated it can be. So we've developed multiple work streams to keep on task and make sure that we're doing what needs to be done. And some of the more significant ones from my administrative end are really the FDA approval, the revenue and billing. This is a closer look at some of those work streams. And then within the work streams, we really drill down into the very specifics. And you can see here for the technical and physics, from control system to clinical commissioning and even shielding. So this is our current leadership team, and I am privileged to work alongside Dr. Kent Thielen. He's our CEO of Mayo Clinic Florida. We have a really wonderful opportunity in that he's also a neuroradiologist. So he is a fan of technology, and he speaks the language in terms of radiology and physics. I'm the current chair of the department and serve as the particle therapy director. Chris Beltran is our particle therapy technical director and our chair of medical physics. And Dr. Hoppy is our particle therapy medical director. And we're very excited that we've recently been able to add to that team. We had significant gaps. We were fortunate enough to recruit Dr. Sungjun Kim in the last year. He will be serving as our preclinical and translational research, translational director for heavy particle. And he's also serving as our research vice chair for the department. Dr. Kim has, in addition to board certification in radiation oncology, he also has a PhD in immunology. So he will be, vital for the development of our translational work. Very exciting news that we are soon to onboard Dr. Michael Story here in Florida. Most people are familiar with his work, and he's coming in as the director of radiation biology within the department. We do hope in the near future that we'll be able to expand to actually have a division of radiation biology under his leadership. And keeping all these pieces together is our wonderful administrator, Katie Moreno. So things we have to think about preparing, we've really leaned heavily on our proton experience. Lots of the physics group and the physician group have had prior proton experience. And so that's been really critical for us in moving forward. We've also leaned quite heavily on our international collaborators. at the existing carbon sites. So things we're considering are the physics control system, microdosimetry, in vitro and in vivo experiments, computational physics, computational radiation biology, as well as treatment planning and clinical trials. So I'm not going to cover all of those things, but just to give you an idea of how far-reaching our collaborations are and how motivated and important those collaborations are to us. This was a collaboration with Australia. Before the facilities could even be designed, we had to work through the designing of the shielding. And so this was a publication that resulted from that shielding work that we did in collaboration with Australian group. This is the physics control system collaboration that we did with Osaka. Really just understanding the specific components of the accelerator. This is the microdosimetry work that we did, starting with proton beam. And so this was internal Mayo work, utilizing this work in proton as sort of a background for what we're going to be moving forward. In vitro cell work, this was all done with proton therapy. This was all from the Mayo group as well. And then moving on with our external collaborations with Medical University of Vienna at MedAustron and continuing that cell work there. And also now expanding into in vivo work. This is from Janet Denby, who's one of our postdocs who has been really leading this work in the mice. This is some of her work that has been accepted for publication. It will be in the Red Journal. And again, this was based on her proton work. Another collaboration that was very successful was some of the treatment planning collaborations that our Vice Chair of Physics, Keith Fiorentani, led with the group in Osaka. Sorry. So in the computational radiation biology space, they've spent quite a lot of time, Chris Lochan and his team, in how we are going to model radiation biology in the RBE. So this is an initial publication that was recently published with Alessio Prisi as the first author. So those were sort of the background, the physics, the radiation biology sort of base that we've been building. And we really haven't talked much about the clinical aspect, and that's because we don't have carbon beam. So Dr. Brad Hoppe developed our first multinational clinical trial that multiple of you may be participating in this call. So this is a comparative effectiveness trial of carbon ion therapy, and this compares surgery and proton therapy for pelvic sarcomas involving the bone. And we have international groups that are working with us. And so you can see in the randomization that those patients that are treated at the carbon ion sites would get carbon ion. The patients in the US would be treated with either surgery and radiation or proton therapy alone. The trial is really looking at the primary endpoint as change in function, and that's looking at the PROMIS 29 physical functioning domain. We have secondary endpoints about local control, as well as some exploratory endpoints as well. The trial seems, non-randomized. It seems very simple and straightforward, but it was quite a huge lift to get this off the ground, and really want to comment and thank our international sites who have opened this trial. I do believe that they've had the initial visit with Heidelberg just this morning. So we're really excited to have these folks on board and supporting the trial. So thinking about our overall aims, we've gotten a good, we've had some great movement in looking at advanced mathematical and computational modeling related to the biological effectiveness. We've worked really hard. We're going to continue to work on developing that international collaboration. Now, with the help of Dr. Kim and Dr. Story, we'll be able to establish a heavy particle immunology research program. And then we'll be expanding in terms of clinical research in the order of where do we need to go. And a lot of that is going to be based on FDA feedback on what will be required for approval. So going back to our facility, this is the facility as it looked probably a month or so ago. This building right here to the right is called the Mangurian Building, and that is our medical oncology chemotherapy area. So it's going to be nicely located with a covered walkway that will join that building to the IOB, the Integrated Oncology Building, which is what we're currently calling it until we have a named benefactor. So just to give you an overview, this is the artist rendering. The facility is going to be 225,000 square feet. It's a $233 million, get rid of that, $233 million investment from Mayo Clinic. And we'll have 3 floors, a treatment wing that's the length of a football field. The equipment in there will be 2 Linacs, 2 CT simulators, 1 MR simulator. We'll have 2 proton gantries, and then we'll have a fixed beam room with proton and carbon. We also have a nice research footprint with an animal holding area with some processing space as well as bench space. So this was sort of the timeline of how things happened. So we announced in 2019 that we were going to be developing carbon ion. And then, of course, in 2020, COVID-19 happened. And those of you familiar with the UT Southwest project, can sympathize and how devastating that can be to a project of this magnitude. But despite that, our group really worked hard, and particularly our physics group, working with Hitachi, with the time difference and whiteboards via Zoom. It didn't really slow them down, but a lot of work to keep that trajectory. Despite COVID, we were still able to ground break in 2022. We'll have facility readiness later this year, and then we'll begin our photon treatments in 2025. 2027, we'll begin the proton treatments, and then in 2028, carbon. Because of COVID, the timeline for proton and carbon did slip slightly due to supply chain, but it's pretty impressive in my opinion that it hasn't slipped more. So we're looking six to 12 months behind from COVID. So this is the artist rendering of our building, the covered walkway, as I mentioned. So this is your typical particle therapy project. Basically digging into the ground is a big hole. Florida, as you saw, the ocean in the background is very different. So because of the water table, we don't build down, we build up. So we started with this giant pile of dirt. But because of that giant pile of dirt, it actually means that our beam line is on the 2nd floor. So it's a bit unique in that way. From a patient and clinician perspective, it's very nice because we have natural lighting, and the treatment corridor is actually on the 2nd floor there with lighting and views. So this is some of the facility schematics. You can see the hybrid synchrotron here. We have multiple ion injectors, and we also have space to expand that in the future. We have the 2 proton gantries, and then the single fixed beam here at the end. This is phase 1 of the project, and so we have the capacity with the equipment, but also the space, the land space, to expand in the future for carbon gantries. So we have the space for 2 additional carbon gantries in the future. We have our standard 3 linacs here as well. And the whole length of the treatment wing is 80 meters. This is a little overview of the research space with cell processing, animal holding. This is the technical and the clinical space included. So here you've got the clinical space. In addition, it's a big atrium. And this is all natural light, which is nice. So there's a big skylight that has light down into the patient corridor. So in terms of facility planning, it's going to be a beautiful patient experience. So here's, again, the overview. You see 2 cranes here, and we have 2 massive projects happening at once with a 5-story expansion of our hospital happening simultaneously as IOB. So here you see the facilities overlay of the actual groundbreaking. And so you can see as you start to see the buildings take shape, this is March. Here we have in June, you can start to see the actual structure where the synchrotron and the proton gantries and the fixed beam will be located. And then this is a more recent picture it's from December, but you can start to see the clinical space coming up. So having the opportunity to build the Carbon Center now, we really wanted to focus on the best technology available now so that we would be future-proofing our system to have it as optimal as we can. So these are some of our specifications for our equipment, specifically for carbon, that I think are extremely favorable. I won't run through all of them, but our physics group has worked really hard to really push the boundaries of what we're going to be capable of doing. Another interesting aspect of our project is to incorporate real-time adaptive therapy into the treatment planning and treatment delivery. Mentioning treatment planning, we have engaged with a software engineering company where we're actually developing our own treatment planning system with this company. It will be a treatment planning system for photon, proton, carbon, as well as multi-ion therapy. And so this is based on our detailed specifications. It's built with Mayo IP. And there'll be a lot of presentations and publications forthcoming on this project. So we're really excited about this. And you'll be hearing more about it this summer. And this is an example of a treatment plan. And this is sort of the rudimentary area where we're at right now. But just sort of a mock-up. Because of the responsibility of what we're doing, we do feel the obligation that if we're not successful in not only building this carbon center here, but disseminating carbon therapy to the US, then we're really not successful. And so part of that is to encourage engagement, not just internationally, but also nationally, so that we can, foster the growth of carbon treatment in the US. So you can see here we had a heavy particle retreat where we invited multiple national leaders to really just learn from them. It was a learning session. And you can see Eleanor Blakely here. I was very proud that she was there as part of our long-standing history at Lawrence Berkeley Labs. We've also developed a particle therapy grand rounds. This is a monthly meeting where we have invited speakers, and it's all via Zoom. And so if anyone's interested in attending these, I'm happy to share the links. If anyone's interested in presenting, I'd be happy to hand your name to Dr. Brad Hoppy, who's in charge of this. It's been very well attended. We usually will have over 100 registries. So the retreat that we held last year was so successful. And so we really wanted to make it more of an annual thing. So we've now developed a heavy ion therapy symposium. It's going to be a yearly event. And as not too surprising, right? The meeting is going to be later this week. It's January 25th to 26th. There's a Zoom option. So if any of you are interested in attending, it's open to all. So we would love to have you attend. It's a 2-day session, but it will become an annual event. So there'll be opportunities down the road. So that's my presentation. And I really appreciate your time. I appreciate the opportunity to be here. And I'm happy to take any questions.
Thank you. Thank you very much, Laura. It's really an amazing project. I mean, we are really looking forward to this new facility. And yes, you have shared, yes, the course, and actually also Professor Hope has shared the link for registration. So we have all the way to register there and to participate. Just to let people thinking about the questions, as a custom of these seminars, we are going to take the group photo. So please switch on your camera if you want, of course, and make, as usual, the best smile so that we can take the picture. Thomas Schreiner. Thomas, you are upside down. It's funny. Schreiner. Okay, great. Anyhow, I will take the pictures, just a few seconds. Sorry, it's going to be there. Just coming. Okay. That's fine. That's done. Okay, so the floor is open to the questions for Laura and for the presentation. You can either make your question directly or put in the chat as you prefer. No questions. Yeah. The presentation actually very okay.
Can you hear me?
Yes. Now.
Hi.
Yes. Hi.
Chiara La Testa from the University of Miami.
Yes.
I have a question. Are you ever going to consider a fully experimental room? So I see that you have in your plan, even in the future plan, you don't have you have like an old treatment room. And let's say as a physicist and preclinical research, I'm very interested in sometime having some the possibility to have certain radiation condition that is very hard to have in a gantry or in a treatment room. So I was wondering if you are ever going to consider that. And also, sorry, to add to the question, if you consider in the future, to opening up to, let's say, external users or some people that wanted to come and use the beam for a project of your interest.
Yeah, absolutely. So wonderful question. And in fact, as we were recruiting Michael Story, his big, almost, criticism out of the gate is, why don't you have a research beam? And so our plan is really, and a lot of it really boils down to finances. And so that would have increased facility cost. And so our thought was, let's get the fixed beam, let's get on the ground, and then we can expand. When we expand to the carbon gantries, that fixed beam will become the research beam. So we'll have a research beam. And, we've been in the position where we are, begging for beam time. We are, so grateful for the beam time that we've been offered. And so, we understand the need of that, and we will definitely have opportunities for researchers to use the beam and to collaborate with us. Absolutely.
Thank you.
Great questions. Did you say you're in Miami?
Yes, University of Miami.
Yeah, you should come up and visit. If you're not coming to the seminar, you'll have to come next time.
Oh yeah, definitely. Also because so I know I gotta go and visit Michael's story because I used to know him where I was working at Brookhaven. He used to come all the time to do radiation, so he knows me. Yeah, with pleasure. Unfortunately, I couldn't come in January, but I mean after the beam camp, to the workshop. But yeah, I will be very interested to see it.
Absolutely, love to see you.
Okay, then we have a question from Mariusz Sapinski. Why a new treatment planning system?
So that's a wonderful question. And I think part of it is that the systems that were available for carbon ion weren't entirely attractive to our physics team. And so we thought that there was internal know-how that we could, capitalize in terms of moving forward with a real-time adaptive and also some RPE modeling. So by identifying an engineer that had this interest, I think we could more customize what we wanted. And again, it all kind of also rolls back to finances. The carbon treatment planning system would, have been a significant investment for us, and we felt like we weren't necessarily going to get what we really wanted. So for a fraction of that, we were able to develop our own, and we think it's going to be a really good one.
Okay, then we have one concerning imaging from Villa Amaya. Why did you decide to use a CBCT for treatment delivery instead of MRI or other imaging technique?
Yeah, that's a good question that I don't know if I have a great answer. We were interested in MR imaging initially, and I hate to say, but it may have come down to finances, as everything I've mentioned so far has. Brad Hoppy was on the call. I don't know if he's still there, but he may be able to comment on the MRI if I can put him on the spot.
Yeah, I think it came down to finances, and I don't think we had something that was already put together and had already been done by our vendor. So that was the rationale behind that.
Thank you, Brad. Sorry to put you on the spot.
Okay, any other question? It seems no. So
yeah, I have one more question. I'm Amaya again, from Techniker. I'd like to know if you have considered to put something regarding the dose verification. I know that there is research, about how to verify that you are delivering the dose where you think you are delivering, and if you have any kind of technology, at least in research or developed, or I don't know.
So this is a little bit out of my field, but I believe that some of the work that Chris Beltrán is doing at the moment is in that space. And so in terms of a formalized approach, my understanding is that he would be collaborating with the other carbon centers in terms of comparing our beam with their beam. I hope I'm answering the question in the right way. Is that what you were meaning?
Well, my question was regarding once you irradiate the tumor, then how do you know where you are putting this dose? So there are some groups I know that they are, for example, trying to measure the activation. That these protons may produce in the tumor. So with SPECT or PECT or similar techniques, they try to reconstruct the dose, where you have put the dose. And I was wondering if you are considering installing a similar system, or you have something, or or this is something yet in research?
So I think some of the publications that I showed, I believe, are doing that in proton therapy. And so our hope is that we will be expanding that to carbon. I don't know a whole lot about the granularity of that. Brad, do you have anything to add? But if I would love to get you in contact with our physicists. If you have interest, we would certainly be open to, fielding your questions with more granularity. But that's my understanding, is that they have the proton experience, and that proton data has been published, and now they're looking to collaborate and expand it with the carbon.
Yeah. I think just exactly what you said. Our physics team is working on that.
Okay, thank you very much.
Thank you. Any other question? Okay, seems no. So, Laura, I really thank you again for dedicating your time for this seminar. If you, we have another question. Sorry, how coefficient we use to calculate the equivalent dose?
It's going to be way over my head. I have full disclosure here. I'm a clinician, so.
I totally understand the situation, Laura. When you talk about hadron therapy, you need to have all kind of professionals around you, because questions can arise from all the directions.
And I have such a wonderful team. Let me write that question down, though, because I would like to answer it. And I'm excited, that there are questions, whether I can answer them or not, because it indicates an interest. And I want to foster that. And so if there's a way that I can respond to that question, maybe I can send it to you, Angelica, and you can distribute it.
Christoph. Maybe he can also send you an email, so you can answer directly to put in contact.
I'll put my email.
Okay.
I don't have all the answers, but I usually know somebody that does.
Okay, then now we have a clinical question. You can breathe. When you're using heavy ion therapy for treatment purposes, does it not have a negative effect on the tissue of the body?
So that's basically the benefit of the Bragg peak, right? So we're trying to minimize the entrance dose and the exit dose to decrease those negative effects on the normal tissue while maximizing the treatment to the tumor. There's also the effect in carbon therapy on the immune system that isn't fully understood, that we think will actually even add or enhance to the tumor kill. Brad, you want to add anything?
Yeah, no, I mean, for targets within normal tissue, we do see, I think there are some concerns of toxicity. And those are things that we just we'll have to work around it and plan around.
Great.
I think that's part of the interest, really, as we understand, more personalized medicine. So we understand which patients are going to benefit from carbon ion therapy, whether that's through radiomics, identifying hypoxia, or through genomics and understanding what tumors are going to be more radioresistant. And so then you're really kind of putting a slant on that risk-benefit ratio if you can more accurately select the patients that need carbon, because certainly not all cancer patients are going to need it.
Yeah, definitely. And okay.
May I ask one more question?
Yeah, sure.
Okay, thank you very much. The last question I would like to do is if you have considered a flash irradiation, I mean, when designing your technology, your equipment, if you have considered leaving this option open. No, maybe you are not going to irradiate now in the flash regime, but maybe regarding the future or research, or if you have considered you adapting or using a technology that allows for this kind of irradiation.
So with our physics team, I would be shocked if they hadn't considered it. I'm not sure where we stand particularly, and is it very far out, or is it, you know, something that would be closer to the horizon? So Brad, do you want to comment on flash for the group?
Yeah, I think the way that I understand it is that we may be able to work with work with flash from a research perspective, but I don't think we'll be able to utilize it in a clinical manner.
And so I think, you know, we will be capable of doing flash, but I'm not aware that we're going to be pursuing it, at least initially.
For example, you didn't install a chopper or a kicker or something that may allow you to have pulses of different length. No, I mean, for example, I don't know, to look into that.
That I don't know the answer to.
Well,
No.
actually, also the point is whether it's useful to use flash with carbon ion. I mean, we already have great advantages with carbons on normal tissues. It's a very open question at the moment. So, yeah, the other question was related again to flash. What is dose rate in ion therapy? Can we talk about flash therapy?
So I was going to pull up some of our dose rate. So our physical dose rate is going to be greater than 5 gray a minute per liter cube. So I'm not completely sure how that compares with flash, but my understanding is that is a very high dose rate. And not sure how that will relate to flash, and not sure that we are, you know, going to be pursuing flash, at least initially.
Okay.
But I did get feedback about the chopper or kicker, is that we do have that capability, but the Hitachi terminology is a little different.
Thank you. So I think we have covered all the topics. And yeah, and if we don't...
Thank you so much for all the interest. Please reach out to me. You can email me with questions, and I can give you detailed responses from the physics side and on the radiobiology side, but would love to be engaged. So don't hesitate to reach out via email.
Thank you. Thank you very much, Laura, for your availability. And if you agree, we can also put this presentation on the YouTube channel of the project. Because we collect all the seminars on the YouTube channel, so you will have the chance to see it again. Okay, so I can leave you to the evening or to the rest of the day for you, Laura, since difference of time, and I invite you to check on the HITRIplus website and the newsletter about the forthcoming seminars. And so have a nice evening, and see you next time. Thank you. Thank you again, Laura. And thank you all of you.
Thank you.
Bye. 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 Ciao, ciao.